Our final talk, we have Mahsa Yazdanbakhsh. She is a PhD student working with Jason Acker at the University of Alberta.
Thank you so much for your introduction. Today I'm going to talk how we can isolate the young red blood cells and use these kind of products for the neonates. So blood transfusion is primarily used to improve the oxygen delivery, and unstable newborns frequently require red blood cell transfusion. This could be due to anemia or underdeveloped organs or respiratory distress syndrome. More than 90% of extremely low birth weight infants are estimated to receive at least one red blood cell transfusion. And the red blood cells that we are using for these kind of recipients is from adult red blood cells. We know that the main structure of oxygen delivery is hemoglobin. However, the fetal hemoglobin and adult hemoglobin are different in terms of their structure. So hemoglobin oxygen affinity is one of the important parameters. We measure the hemoglobin oxygen affinity by P50. P50 is defined as the partial pressure of oxygen in the blood at which the hemoglobin is 50% saturated. On the right side, you can see a graph which we get from a Hemox analyzer. And the blue line shows the P50 of the adult red blood cells, and the red line shows the P50 of the infants. So you can see that the P50 of the adult red blood cell is higher than the infants. And the higher P50 means lower hemoglobin oxygen affinity, and lower P50 means higher hemoglobin oxygen affinity. So after blood transfusion from the adult donors to infants, the red cell concentrates will bind oxygen less tightly than those from preterm infants. So here's the work that we have published in pediatric research, and in this work, we quantified the in vitro hemoglobin oxygen affinity shift, or P50, of cord blood after titration with adult red blood cells. And also in another part of the study, we also looked at how the biologically aged young red blood cells and old red blood cells would also affect on the hemoglobin oxygen affinity of the cord blood after mixing. So I don't go in depth for the results. Here is the summary of the result that we got from this research. Addition of adult red blood cells in vitro can significantly impact the hemoglobin oxygen affinity and hemoglobin fetal levels. Also, by increasing the amount of red blood cells transfused to a preterm infant, there will be a significant increase in P50 and decrease in hemoglobin fetal levels. And in terms of the biologically aged red blood cells from adult donors, the old RBCs in adults may briefly reduce the tissue oxygen delivery and decrease the oxygen release in infants. So all the data that we got from the research showed us that the young red blood cells have a minimal impact on the P50 and underscores that there is a need for high quality red blood cells for transfusion of these recipients. So this question comes up that can we produce the red cells which contain a high proportion of young red blood cells? And the short answer is yes. But the method that we use for the research that I shared with you was with the Percol method. In this method, we layered the red blood cells with Percol, and then we had a centrifugation. Since we know the young red blood cells have lower density, they were on the top. In the middle, we had Percol, and at the bottom of the tube, we had old red blood cells. And then we tested different parameters. But we know that the Percol is toxic, and we are not able to use these kind of products for blood transfusion. So here is an alternative approach that other groups have done previously. They have used the Cope cell separator for isolating the young red blood cells, and they have used these kind of units for the thalassemia patients. But the challenge of these units was that the first one was that because they have used the 50% of each unit, there was a low volume. Also, there was a risk of alloimmunization, and there was a high cost for these kind of recipient. But because we are going to use these kind of units for infants, it would be possible because for infants, the volume that we use for transfusion is almost 10 to 15 milliliter per kilo. So there is no like any drawbacks in terms of the volume or any alloimmunization. So I didn't mention it here, but we did the same with the units. So during the flow centrifugation, because the young red blood cells had lower density, they first come out of the centrifuge, and then we had others as well. So we collected 4 different fractions from the Cope machine, and here is the result. So the first one shows the youngest red blood cells, and the 4th tube shows the oldest red blood cells. And you can see that from the P50 graph that the first tube had lower P50, suggesting higher hemoglobin oxygen affinity, and last tube, which shows us the oldest red blood cell, had higher P50, which is the lowest hemoglobin oxygen affinity. And also, we measured the deformability of these kind of RCCs, and elongation, O hyper, and I mean, all of them showed us that the first 2 tubes had higher deformability compared to the last tube, which had the highest proportion of old red blood cells. So here is the summary. A distinct population of young red blood cells can be efficiently isolated from the RCC units, and these young red blood cells shows us higher deformability and higher oxygen affinity, which are more suitable for the infants. And we can eliminate some methods like Percol by having this approach. Thank you, and I'd be happy to take any questions.
There are some people with congenital high hemoglobin F. Would they be a suitable source of donors for your patients?
I'm sorry, can you just repeat it? I didn't understand
Sorry, there
that.
are some people who have a high hemoglobin F as a genetic variant. Would they be a suitable donor?
Actually, we have done this research before, and we have looked at the donor factors like the age and sex of the donor, and we can say that the senior and frequent donors had higher proportion of young red blood cells, and maybe in future, because they had higher proportion of young red blood cells, we can use those units for infants.
Thank you.
By extension, would you think that this has applicability for intrauterine transfusions as well then, for fetal?
Actually, we are just in the start of this work, and there are many different tests and parameters that we need to do. But I know that there is another group who are in the Europe, and they're working on the cord blood as well, and they're working on a clinical trial. So maybe by having more experiments on these kind of products in the future, we will have also a clinical trial.
Thanks.
How do you define the young red blood cell in terms of cell lifespan? 120 days, you call it 5 days, young enough, or what exactly, how you define it?
Actually, the lifespan is 120 days, but when we call them young red blood cells, we can't actually say that it's like 10 days or 15 days. We just collected them based on their density because we know that it's different. And in another part of this study, we are also going to validate their age as well by doing like the band 4.1 A and B ratio to see if they are actually young and old, and also some CD markers like CD71, 47, and 235.
So is it correlated or not correlated to their age?
We just started. I don't have the data for that. Yeah, but yeah, just for the Western blot that I have done for the band 4.A and B ratio, it was okay. It was showing us that the isolation that we have done correlates with the band 4.A and B ratio that we expect in young and old RBCs.
All right, thank you.